Good day and welcome to part 1 of the Morehouse Healthcare Telemedicine webinar series. Today's webinar has been made possible due to a collaborative effort between Morehouse School of Medicine, Morehouse Healthcare Telemedicine Program, and the Georgia Health Information Technology Extension Center. We will begin with a brief overview of the MHT Telemedicine Program presented by Dr. Wakitria Smith, followed by a summation of Georgia High Tech presented by Executive Director Ms. Carmen Hughes.
Good afternoon. How are you guys doing today? So I am the Medical Director for Morehouse School of Medicine MHT Telehealth Program. So we're leading the advancement of health equity amongst the minority and underserved communities by integrating this new technology that we're super excited about. We began our telemedicine program, we launched in September here at Morehouse Healthcare. Currently we have 11 lines of service. So the reason that we decided to get into telemedicine, and again, in terms of leading the creation and advancement of health equity, is extremely important to us and our patient population to serve them by, filling those health gaps and access perspective. So from the beginning of the program, what we were trying to aim to do is do a health assessment to kind of look at the needs with our patient population. Part of the issue that we found were patients have lack of transportation, and we have a very high no-show rate. And then patients weren't able to get in or have access to the type of specialist care that they really needed to optimize their health. In addition, we realized that, we are here in Atlanta, Georgia, and we are faced with these type of inequalities, but we can only imagine what's taking place in our rural setting with our rural partners. So it's important for us to kind of test out telemedicine within our network so that we can perfect it in an effort to eventually go out to our patients or the population that's most needed in the rural setting. So right now, what we've been doing as far as telemedicine is concerned is utilizing it to have patients who have chronic care management type issues, who can't necessarily come in on a monthly or even a quarterly basis. So allowing them to utilize telemedicine to do blood pressure checks, medication adjustments. Also, between our clinics, we have 2 clinics, one that's in the south part of the city and one clinic that is in the actual city of Atlanta. And there is even a disparity between the clinics. One clinic has mostly our specialists who are housed there, with other clinics family medicine. Our patients who are in family medicine clinics may need specialized care, but it's very difficult to them, again, for a transportation perspective, to get all the way to our other clinic. So to bridge that gap, we've utilized telemedicine to have visit types for our specialists between the other clinics that we have. And then a third way we've been doing telemedicine is to look at our international health gaps. So we have some patients who are here sometimes, or they're away in the Bahamas and places of that sort, who really need some specialized care, whether it be for bariatric or psychologic care. And so we've been able to utilize telemedicine in that forefront. So we're really excited about what we're doing. We're more excited in terms of having the opportunity to have some partners so that we can provide our services, whether it be cardiology, sleep medicine, neurology. We have nephrology as well. We really want to establish this care to let you know what our services are so that you can provide the best care for your patient population.
Thank you, and now Ms. Hughes.
Good morning, everyone. Hope everyone can hear me okay. Cheryl, let me know if otherwise. We're happy to partner with Morehouse Healthcare in this initiative in this webinar. I want to just tell you a little bit about Georgia High Tech. It's the Georgia Health Information Technology Center. And it's a program within the Health IT Division of the National Center for Primary Care at Morehouse School of Medicine. When we are focused on education, training, and outreach to practicing clinicians. I serve as the Division Executive Director, and Dr. Dominic Mack is our Executive Medical Director here in the division. We're primarily a grant-funded entity designed to provide education, resources, and to help clinicians in the state and the region to, as I like to say, promote interoperability, care quality, and enhance health outcomes through the use of technology, health information exchange, and other digital media. We partner with state organizations such as the Georgia Department of Community Health, Department of Public Health, the QuinnQIO Alliance Quality, and many other partnerships, professional organizations, including the State Health Information Network, or also known as GHIN, here in the state. So specifically, to give you an idea of some of the resources that we provide within our division, we provide direct and individualized education and technical assistance on the MACRA Quality Payment Program, the Medicaid EHR Incentive Program, which is now known as the Promoting Interoperability Program, and other clinical practice transformation efforts. We have boots on the ground, we have electronic communication, e-learning tools, webinars, virtual office hours, so a great amount of support. We also have certified patient-centered medical home experts on our team, and we're involved in numerous research projects to support health information technology and support interoperability, and as well as telemedicine and telehealth. Through our Regional Health Information Exchange, which is also known as Georgia High Tech, we're able to facilitate the electronic exchange of patient data at the point of care. We are a node on GHIN, as I mentioned, and connect physicians, hospitals, and many ancillary points of care in the patient care continuum. So extremely important work that we're doing here. But specifically, as we talk about telemedicine and telehealth, I want to just kind of look at that bridging the gap of health IT with telehealth. And so when you think about health information technology, what does it really include? So I like this graphic from the American Telemedicine Association because, again, it helps to bridge that gap between the technology and the healthcare delivery system. And so we know that the goals and the activities of telemedicine and health IT are certainly complementary and they're synergistic. However, telemedicine and telehealth is really not a type of IT, health IT, and so we talk a little bit about that. And while telemedicine and telehealth are dependent on the use of telecommunications and other advanced technologies, as we know, it's really a delivery of patient care through the use of technology. And I think that's an important distinction to make because I do hear that quite a bit as we're traveling, meeting with practices in hospitals that, they think about technology or telemedicine as a technology, and it's more, again, a mode of patient care. And all applications, health IT components, are really, of course, they're interrelated. So the EHR supports the care delivery system in multiple modes. And I won't go into a lot of detail on this, but it's something really that's a passion for me. But when you look at telemedicine and telehealth, they're really facilitated by access to an interoperable EHR, electronic health record system. And you have to have a fully functional EHR, and that's extremely important to deliver that quality of care through the telemedicine and telehealth. And it's vital, again, to the impact of the quality of care really on any practice modality, including telehealth, health information exchange. So I want to just give you a practical example of what we've done here at the National Center for Primary Care at Morehouse School of Medicine. And one of our recent projects and opportunities, we received some funding through the USDA to provide telehealth equipment and also develop education curriculum to 6 rural Georgia counties. Made a great impact on giving them the technology, the education to deliver that the telemedicine health. And the education topics that were covered and covered several areas, that are important to patient care in rural areas. That included things like chronic care management as well as the important topic of health information exchange. So that just really kind of gave you an idea. And we, as you can see through this map, where we were centered throughout the area, or throughout the state, in very rural areas of the state that were identified through the State Office of Rural Health and USDA. So again, practical examples of how we are helping to support the telemedicine telehealth efforts. With that, I will turn it back over to our facilitator.
I now present to you today's webinar entitled Best Practices in Telemedicine, the Right Virtual Care Services for Your Practice, presented by Dr. Orrin Mechanic. Additionally, we will have a panel Q&A discussion facilitated by Dr. Mechanic, Dr. Smith, and Ms. Hughes. In compliance with ACCME guidelines, None of the following presenters have any financial or other relationships with the manufacturer of any service discussed in today's educational activity. Moreover, the Morehouse School of Medicine is accredited by the Accreditation Council of Continuing Medical Education to provide continuing education credits. Subsequently, the Morehouse School of Medicine designates this live activity for a maximum of up to 1.5 AME-PRA Category 1 credits. The objectives for today's webinar are to identify the benefits and drawbacks of telemedicine for physicians, to explore the ideal service lines for providing telemedicine care, to examine the industry best practices for offering telemedicine services, and to evaluate health outcomes associated with delivering care via telemedicine. And now, Dr. Mechanic.
Hey everybody. First of all, it's an absolute honor to speak here to you all. I was able to look through a lot of the questions and see exactly who's being represented here, and it's heartwarming to see so many folks that are interested in telemedicine for their patients. So let's go ahead and get started over here. First and foremost, what is telemedicine? And this is the question that everybody asked me. I was in a meeting this morning and someone asked me, well, what exactly is this? And so I'll give you a little bit of an example. I have a little mole over here. I've had this for maybe 10 to 15 years, maybe 20 years. Now, I'm fortunate enough, I'm in medicine, and I think it's okay. I think it's benign. But let's say I wanted to see a dermatologist, and I'm in Boston, Massachusetts. It's about a 55-day wait, and that's downtown Boston with the number of healthcare centers we have. And it's still a pretty long time, especially if you're concerned. And so imagine if you're just able to take a picture of this and then send it on to a dermatologist, and at a minimum get some reassurance, or maybe if it is something scary, you come in a little bit sooner. And so that's exactly what telemedicine is. So today we'll give a foundation of telemedicine. We'll really understand what this is. So first and foremost, we will look at the different modalities of telemedicine. There are different malpractice and licensure laws that we have to adhere to. We'll talk a little bit about parity and reimbursement, especially because in Medicare, in January 2019, Medicare actually passed on laws. So we'll take a superficial dive at first into this, and then if you have any questions, I'm happy to answer them. And then we'll look at the value of healthcare. Why do we do this? Are we improving access to care? Are we trying to reduce total medical expenditures? All of this is important for our healthcare setting and important for our patients. And then I'll give you just two examples, one national, one international, of effective telemedicine, and there are hundreds of examples out there. So first and foremost, let's just briefly talk about the foundations of telemedicine. When you speak to me or anybody else that actually helps different departments and organizations incorporate telemedicine, you really talk about three things, and that is one, synchronous care. That is real-time communication. So that is your patient to doctor, and quite honestly, that is what we are doing right now. And that looks sort of like the picture attached. The second one is asynchronous care. So imagine I took a picture of my mole and I sent it over to the dermatologist. That's a store and forward. And then finally, the third one is remote patient monitoring. So imagine a patient with congestive heart failure. Congestive heart failure, most patients that come in, you have, I think, a 30% readmission rate to the hospital, and that's pretty high. And so we can actually do the same things that we're doing in the hospital, but keep them healthy at home. We may take blood pressure recordings, we may measure weight at home, and then we can, titrate medications and keep them healthy, where they are. And so that is, first of all, the modalities. Always think about synchronous, asynchronous, remote care monitoring. The second thing to really think about foundations is licensure, and this is incredibly important because as clinicians, you're only able to practice where you're licensed. So, for example, Dr. Smith, I presume, is licensed in Georgia. I'm licensed in Massachusetts. If one of the snowbirds in Massachusetts flies down to Georgia for the winter, Dr. Smith can care for this patient, but I can't. The patient has to be located in the state where I'm licensed. There's a telemedicine pact, and that facilitates licensure a little bit easier. There's no real telemedicine license that allows me to practice medicine in a different state. So whenever you talk about practice of medicine, reimbursement should be something that we do discuss because it is important. And first of all, parity laws, you'll hear about this a lot. That's the quality of telemedicine payment, the amount and the coverage. So 2019 actually has some Medicare reimbursements that we'll actually go through. Now, recall that private payers, it's actually state-specific. So in Massachusetts, where I am, we don't have parity. That means we have to look at kind of unique ways of practicing telemedicine, but without reimbursement. So right away, thinking about an accountable care organization, we can really leverage our desire to make patients healthier and actually have that be a cost saving, and leveraging telemedicine to do that. So this is briefly the Medicare codes. If anybody wants the actual codes, provided they are available online, and you can always reach out to me as well. So again, Medicare actually nicely broke this down into 3 different segments: synchronous, asynchronous, and remote care monitoring. Synchronous may be virtual care check-in, it may be an interprofessional consultation. So if Dr. Smith and I have questions for each other, there can actually be some reimbursement. And this oftentimes happens in medical centers all the time, as we know. Asynchronous care is an example of the dermatology. You can actually get compensated for seeing that lesion. And then remote care monitoring we touched upon with the patient with congestive heart failure. Now, we need to talk about what is it that we're doing with improving healthcare? What exactly is our goal? I was in a meeting this morning and we talked about, integrating telemedicine for primary care settings. We have to really think about, what are we doing? How is this valuable to whomever? And we've all seen these ominous graphs over here on the next slide for the patient outcomes. We're ranked 29th in health access and quality. And that's according to a paper just last year by the Lancet and funded by the Gates Foundation. We're still, 29th in health access and quality, and we break it down and see exactly what we can do. So maternal fetal mortality, for example, we can really access these areas that need the most assistance and leverage telemedicine. And then patient costs, we're number 1. So the graph on the right side of your screen, we've seen these before. We spend a lot of money for presumably not as much value, because our outcomes would not be as good as places that spend less money. So we have to always consider the value proposition. We have to consider how telemedicine may provide value to maybe the patient, maybe the provider, and maybe the whole healthcare system. Sometimes, if you do an A1C and the patient is at home 30 miles away, you're providing some value to the patient. He or she doesn't have to, drive in, pay for parking, lose days from work. But you're also definitely providing value to the provider. You're providing value to the entire healthcare system by allowing maybe a patient who may be sicker to actually come in and actually see you as a visit. So we definitely need to know the benefits of telemedicine whenever we consider any project. So I've broken it down to 5 benefits of telemedicine. These really overlap a lot. They are just a theme that I use as a foundation, and then we can develop each one of these a little bit further. So first, improved access to care, reducing health disparities. These are just a couple examples that I highlighted. So the Rural Health Information Hub, if you go there, you can actually look at different programs. University of Mississippi is one example. I had the privilege of visiting them, and they have one large academic medical center, and much of the state is rural, and they really need to be able to access those patients. And so right away, you're providing access to care. We also have the University of Alabama at Birmingham. They said, okay, let's provide palliative care to rural areas. And again, these are just couple of examples that you can really say, this is our case that we're going after. And that's how I start every program. We go after a single case. We try to tackle, we try to figure out exactly what benefit it may have for patients, for the providers, for the healthcare system. And so the other, just to kind of break it down, we have improved access to care. We have decreased hospitalizations. Imagine risk of nosocomial infections. Imagine that being a thing of the past for those that are non-clinicians. Nosocomial infections are all the illnesses that actually happen in the hospital. So acquired pneumonias, acquired, MRSA infections, things of that sort. There's a financial risk to patients in hospitals when they are hospitalized. Clearly, we've all had loved ones that have been hospitalized and then trying to figure out how to pay the bills. It's expensive. Hospitals actually are disincentivized to admit. It's quite fascinating speaking to a lot of C-level executives. We're trying to keep these patients out of the hospital because we get penalized for readmitting them oftentimes. And then lost days from work that we already touched upon. We do have over here decreased out-migration as well. Out-migration is when a patient may go to another healthcare system. So I can't get my lesion looked at on my mole over here for 55 days by a dermatologist. I may go somewhere else. And once I go somewhere else, for a healthcare system at least, that at least puts me at risk for getting my care at a different healthcare institution. I've lost a patient. And so we can direct actually patients within our system, which is great. Provide them a one-stop shop. All the studies have showed that it's increased patient-provider satisfaction. That's actually my fourth bullet. I'm sorry for that typo over here. It is a bolded bullet because it is one of the most important things. Patients love it. Providers like using telemedicine. And finally, reduce total medical expenditures. And as I said, there's some overlap with migration and all that. But effectively with TME, you think about virtual care visits, me talking to a patient just very briefly, just really addressing what their concerns are for 7-10 minutes, may actually be less costly to the insurer, to the patient, to me, than them going to the emergency department and then having to visit them in the emergency department where healthcare costs are just that much more expensive. The ticket to get into an emergency department, as we all know, is upwards of $1,000. So you can imagine the number needed to treat, the number of patients that we actually can treat in virtual care visits is pretty high to equate just one emergency department visit. And finally, and most importantly, improve population health. And the reason that ACOs were introduced is that we're actually incentivized to make them better, which is the beauty of healthcare right now, at least, and what we can really do with telemedicine is make patients better. So how do you start a program? You have to make a program that is patient-centric, just to summarize, provider-centric, hospital and system-centric, and then healthcare-centric. We're ultimately trying to better our nation's healthcare, and so we really need to focus on that. So this sounds expensive. This sounds really expensive. All this technology and using technology that our patients may not be able to afford. It sounds really expensive. And so I'd like to encourage you to really think about how we can actually mitigate costs. So healthcare is already expensive. We know that. We don't want to add costs. At least with my programs, I don't want to add costs. So we talked about virtual care being less expensive in the emergency department. Then think about global payments. You have a healthy, pregnant population that potentially doesn't have to do an oral glucose tolerance test in the clinic, wait a couple hours, and really spend most of their day and your day and your staff's day doing something that oftentimes is a normal result. And so maybe we can have them do just a glucose at home, teach them how to do education. We can suddenly leverage at-home testing. A1C testing has now been brought at home. We do it sometimes with fecal occult testing for colon cancer screening as opposed to a colonoscopy. Not to say that is best practice, but oftentimes it's less expensive. And so those are options that patients in healthcare systems may at least consider if, quality metrics are the same. Decreased hospitalizations has tons of incentives for our healthcare system. So I actually suggested this morning that we, can purchase machines for patients. We can, if we're saving this much cost, how about we give it back? And so those are some ways to look at it, because that's usually a barrier. And there is some literature for cost effectiveness. I just quickly perused the internet. I can't vouch for the methodology, but I can say that it's something that is a hot topic and that I hear about a lot, is How do we use telemedicine for, post-operative parathyroid surgery, just looking at the incisions after surgery, making sure they're okay and maybe not bringing the patient in. You'll see this a lot in EICU has been a hot topic, but also the previous slide was orthopedic care as well. So, how do we practice medicine? This is a whole new practice of medicine. Telemedicine, we're practicing medicine via web conferencing. This is something new. And the amazing thing is that it's already everything that we have. We have many of these tools at home. Now, I can't vouch for any of this, these Amazon available tools, but we've all seen these around. The glucometer that I've shown is a Bluetooth glucose check under $50, and you can frankly purchase it, once a year, and you're saving on the cost to park at the medical center. Just for one example, Bluetooth glucometers, Bluetooth stethoscopes, and so we have these tools, and oftentimes, the tools are just getting better. So for those with an iWatch, I haven't bought in yet, but they're really trying to figure out how to detect AFib. Now, some arguments of, hey, is over-testing and is this AFib that may have been undiagnosed? Is it actually clinically meaningful? And that's something we do need to figure out. But at least in regards to the practice of medicine, I'd like to highlight we have a lot of these tools already. So I'll give you one example of the VA. The VA has done actually a wonderful job in implementing telemedicine. So I'll just read some of the stats over here. In 2012, 150,000 veterans received care remotely. In 2015, 667,000 veterans received care remotely. They've almost quadrupled the number of veterans they cared for via telemedicine. And they saw cost savings. Not only did they reduce readmissions, again, that's better for the patient, improve chronic disease care, which is better for the patient, improve mental health services, again, better for the patient, but they actually did it cost effectively. They saved some money, and that adds up for at least the VA. And just on the right-hand screen, I don't know how many of these they've actually started, but as of last year, they had 2019 goals. And they're pretty inspiring, actually. You have dermatology, telecardiology. They have telemental health, which, as we know, is probably one of the most important things that we can implement, especially for our veterans. Not only that, but our entire nation. And so it's pretty inspiring what they were able to do with telemedicine. And they're able to track their goals, and track outcomes, which is incredibly important. Then I'll give you one example of international care. And this I found inspiring because tuberculosis care in Nepal, and this is just the one example that I'm using, as we know in India and many aspects of the world, are one of the leading causes of death. And the treatment for this is actually, we have the medicine figured out. It's the direct observed therapy, where you're actually just ensuring medication adherence. I don't know if you've ever tried to take a medication, but adherence, even for doctors, nurses, is pretty poor. And so we need to figure out how to get these very important medications that you cannot miss for patients with tuberculosis, and make sure that they adhere to these medications that are often difficult to take. And so what we're taught in medical school is that you actually have someone go door to door and ensure that they're taking medications. And that works pretty well. But imagine, for example, on the screen in Nepal, where you can suddenly have someone check in and ensure that you're taking the medication. Suddenly you've maximized your adherence, which is wonderful. And so the Bill and Melinda Gates Foundation, who sponsored this, they're still trying to track outcomes on, and we're still, I'm still learning about what their outcomes are. So at your institution, start thinking about ways to leverage telehealth to provide just excellent coordinated care, and maybe at a decreased cost. So how do I get started? These are the frequently asked questions. You need to know the modalities. What are you trying to implement? Is it synchronous visit? Is it asynchronous like the mole? Or is it just using, the phones that everybody has to leverage the HealthKit app and really track their blood pressures? You need to think about licensure, because you should do it, in a place where you are licensed to take care of the patient. Malpractice-wise, I did gloss over this. Many of the malpractice, and I would confirm this with whoever covers you, they will cover telemedicine as well. Again, their primary goal is that the patient is actually in the state where you're licensed to practice medicine. Know its value. Know what you're doing for every stakeholder in your practice. And that includes the physician, that includes the staff members as well. We try to bring everybody to the table because, you know, if we're taking pictures of lesions to show a dermatologist, if the doctor taking the picture, that may be okay during their visit, but if it's a staff member coming in afterwards and the staff member who may be a technician already has their hands full, that may be added work, so we really have to figure out how to streamline that. Lastly, just to have a slick kind of use of the words telemedicine and telehealth, I use it interchangeably, but just so you know, telemedicine is the actual practice of telemedicine, of medical care, whereas telehealth really includes everything that we talked about. You know, we're talking about malpractice licensure, so this is more the telehealth topic. And finally, as my last slide, I'd just like to say that you will encounter barriers along the way. I've encountered tons of them, and getting buy-in from every person in the medical center, patients included, is important. But, for example, just 3 months ago, I don't know who saw this, but the robot doctor at Kaiser. Suddenly I had, you know, the chief legal officer email me. I have different stakeholders saying, what is this robot doctor? Is this what Dr. Mechanic has been doing this whole time? And so you have to be cognizant that, you know, this is the New York Times, these are all these papers and publications cover CNN and Fox News about robot doctors. So you really have to sometimes encounter these barriers and really just re-educate, because this is a new field. This is something completely new to so many people. So we have to do it well, we have to do it right, but you will expect some barriers when you're delivering a new healthcare delivery modality. So thank you very much. At this time, I'd like to open it up for questions.
Thank you, Dr. Mechanic. Dr. Smith and Ms. Hughes are also available for Q&A. Hi, Dr. Smith. Also, I'd like to point out that the webinar presentation is available for download. That can be found in the lower left corner of your screen. Additionally, the resources which Dr. Mechanic shared today are also available for download. So we will begin with a question for you, Dr. Mechanic and Dr. Smith. And this question comes from Baltimore, Maryland. And the webinar attendee asks, which strategies have been employed via telemedicine to reduce health disparities among minority populations?
So I will speak to what we're doing here in Morehouse Healthcare. So one of the implementations we are utilizing is for chronic care patients. So we have received a grant for a treatment pilot program where we're targeting diabetics or patients with hypertension that are not at goal, looking at if they have had any transportation issues or just poor follow-up, utilizing a nurse manager as well as myself, as well as a pharmacist to kind of educate on a monthly basis. So we did purchase them a scale, glucometer, and blood pressure cuff so we could do home monitoring for these patients and then adjust to the medication regimen. So what we're going to be looking at in the next few months is what the outcome is in terms of, have you lowered their diastolic systolic blood pressure, slows their A1C after being enrolled in this program. Additionally, in terms of just from a access perspective, how the patients feel. Has it improved their access, if that was the biggest issue for why they weren't adherent to their regimen. And then just also looking from an educational perspective, like sometimes patients really just need that one-on-one face-to-face time more frequently to really educate them on what's going on, how they should be taking their medication.
There's rural and then there are urban issues. So I know we just talked about rural, so I'll give you an example at least about an issue that we have in downtown Boston, and that is our opioid epidemic. It doesn't necessarily answer your question directly, but it does address one type of desperate kind of care, and that is folks with access to care and folks that are just marginalized because of the opioid addiction. So having that at least framework for when we kind of move forward, coming up with a pilot for example, on prescribing Suboxone and trying to figure out how to touch base with these patients. It's something that's been on my mind. It's something that we at least have been introduced to the system. We're still trying to, I think, tackle a lot of these issues within the medical center, and so we want to figure that out first before having a telemedicine program. But that's just one just easy example, at least in the urban setting, which is the city setting over here, where we see a lot of the disparate kind of care. But there are countless of other programs and opportunities, at least, with telemedicine.
Thank you. Dr. Smith, we have a question specifically for Morehouse Healthcare. Would you mind sharing the platform that you're using, and if a clinician is currently in Cobb County, this is a very specific question, are you able to support their practice by providing telemedicine services?
Group visits, either for the patients or group visits, shared visits with other specialists. We definitely can provide some support for patients in Cobb County. That's something that, you know, if there's a need there, we're willing to provide that access and bridge that gap. Hope that answers your question.
Wonderful. Thank you. Ms. Hughes, we have a question for you. Are you familiar with any programs, are you familiar with any CME initiatives which incentivize telemedicine use by providers or researchers?
Hi, this is Carmen Hughes. So I think it should it be CMS incentives or CME? If CMS, I will say that at this point.
Yes, Center for Medicare and Medicaid.
Okay, so CMS. So I have not seen any dollars specifically allocated for telehealth at this point at the provider level, but we will continue to watch for those fundings here at Morehouse School of Medicine and through our program as well as Dr. Smith's program, and push those out through our communication.
And I think that Dr. Mechanic kind of discussed in 2019, one of the things that took place as far as CMS is concerned is they kind of lifted some of the restrictions that you have as far as practicing telemedicine and created more codes that you can bill for. So one of the biggest buzz things that falls under this umbrella is chronic care management as well as transition of care. So those are spaces and places that, you know, we really haven't thought about utilizing telemedicine for previously, but now that we have more codes and now that, you know, this is something that they're really pushing us towards doing to prevent hospitalizations, I certainly believe that chronic care management particularly can be done utilizing telemedicine and telehealth.
Dr. Smith, I totally agree with that. The chronic care management, while certainly it could be challenging initially to put those processes in place, it is definitely a worthwhile effort from a revenue really perspective as well as patient care, and can be done through telemedicine. As well as CMS has, you know, their big initiative is reducing physician burden, and that's across the U.S. So as we look to determine how to best do that, telemedicine, telehealth, and virtual care certainly falls within that physician burden reduction plan.
Wonderful. For the very comprehensive answer. Okay, our next question is specific to insurance types. Well, reimbursement via insurance. Dr. Mechanic, Dr. Smith, and Ms. Hughes, feel free to answer. Are you familiar with the insurance types which provide reimbursement, or do all insurance types provide reimbursement for telemedicine services?
So I will start this out with not all insurance types, at least private insurance, provide reimbursement. It's very state specific. And so I will comment on my state at least. We are lagging behind almost every other state, and we do not provide by and large reimbursement. So it does.
So it varies in terms of state laws, and then also you have to separate things in terms of the Medicaid versus Medicare and then private insurance. There are three different beasts. It's kind of difficult to really get into it. In terms of Medicaid, most states, particularly Georgia, is very Medicaid friendly. In terms of reimbursements, though, in order to be reimbursed for Medicaid patients, their presenting site has to be within a clinic. So you really can't do home telemedicine unless you have another funding source, which would be out of pocket. So that's the Medicaid population. Again, Medicare, we kind of talked about that in terms of some of the restrictions. They previously had a rule into effect, but again, 2019, the game has changed as far as Medicare. As far as commercial insurances, again, it kind of depends on the state. Most of Georgia, I would speak specifically, does cover telemedicine. However, it may be restrictions in terms of what platform you utilize. So, for example, in Georgia, Cigna is one of the providers. They are telemedicine friendly, but they require you to utilize either MD Live or Amwell, if I remember correctly. So it would behoove you to just kind of look into those insurances case by case to kind of see if there's any type of restrictions in terms of the platform. I will be honest, MD Live and Amwell are the mega stars as far as platforms for telemedicine. So anything that's being done or created or reimbursement from that perspective, they've kind of been leading the charge since they've been around for so long. I hope that answered your question.
Thank you. Our next question, Dr. Smith or Dr. Mechanic, are you familiar with any peer support groups or patient visit groups which have been facilitated via telemedicine? Is that an allowable encounter, so to speak, in telemedicine?
I'm happy to comment that the beautiful thing about telemedicine is that there are a lot of, it's such a new field that there are so many new solutions out there, and there's solutions because a lot of these young innovators kind of come up with an idea and use it as telemedicine. So I know the question was peer support. There are absolutely programs out there. Now remember, they're startups, and at least in my experience, they're new, they're fresh, they are malleable to actually what you want to have done. And they actually, there's one, and the name escapes me, but they actually have a peer support where you have other folks kind of log in at the same time, and you actually have some sort of counseling session or really whatever you may want. There's a lot out there, and I know Dr. Smith mentioned Amwell and MD Well, and there's so many other platforms out there. And we've been very, I know this is slightly off topic, we've tried to uniquely find systems that maybe are not that costly, that really give us that HIPAA security. They may not give us, scheduling to have it be an online clinic, but they give us the functionality. And so there's a lot out there. I'd encourage you to go to your local, there are regional telemedicine centers that will actually provide you with a lot of free information and advice about this. And it sounds like Georgia High Tech is one resource at least.
Yes, and so some group visits can be done, but again, it kind of goes back to your insurance and what the platform that you're utilizing. So one of the things that we discuss and talk about, give our patients options for if they do not have insurance that allows for telemedicine to occur with their insurance policy or with the platform that we utilize. You can always be creative because a lot of these insurance companies have pretty high deductibles. So they're able to sign a waiver and just pay the out-of-pocket fee, which as a group, and again, is for access, is why we provide for our patients. Our out-of-pocket fee actually isn't that high. It's typically maybe a few dollars higher than what the most patients' copay or insurances are. So that's another way of doing it. So I think that, when you're approaching or this particular venture, just know how to be creative, know what the rules are in your state, because each state is different. Again, Georgia is kind of gray, so there's a lot of wiggle room in terms of what's provided and how it's been provided in the South. It hasn't been done yet. So, yes.
I'd encourage you to try to be innovative with the way that you are at least thinking of healthcare expenditures and reimbursements, because again, if you are doing depression screenings for an ACO and you are able to touch a patient the twice a year that's recommended or whatever it may be to get that reimbursement, then it may actually be beneficial and it's better for the patient ultimately. So maybe better to look at it in more than one way, cognizant that reimbursement is not always up to par with in-person visits.
Thank you. Our next question comes from a webinar attendee who writes that they have a very small very small rural practice, and they would like to know, in considering whether or not telemedicine is best for their very small rural practice, what steps should they take? And the second part for Ms. Hughes, can they receive support in implementing telemedicine services if they elect to from Georgia High Tech?
So I'll take the second part first. So yes, if there are telemedicine resources that need to be integrated into the EHR system, we can help to support that integration.
I would take the first portion of the question. I suggest doing a needs assessment. So what is your purpose in terms of the patients that you're seeing? I don't think any practice is too small, especially if it's going to provide access and it's going to improve the quality of care that you're being delivering. So just find out what your needs are. Are you finding that you are overwhelmed, or patients aren't able to get into specialists or have to travel a very long way to get into specialists? If you find out that you have a lot of patients who have like psychiatric disorders and you really just need to get them plugged in, as discussed by Dr. Mechanic before, in terms of like opioid addiction, do you need any type of help in bridging of care in that particular space? So whatever your needs are, you look at those, and then definitely consult with ourselves here at Morehouse School of Medicine, where we lead advancement health equity, so that we can provide care. Because it may be something as simple as half a day of a week you plug people into a subspecialty clinic at your office, or you may want to start small, maybe do once a month, half a day once a month, and we could provide that bridge care for a variety of services. And like Dr. McKenna said, one of the biggest things that that's been plaguing the rural areas is this opioid addiction. So we do have psychiatrists here who specialize in Suboxone and addiction care. And the one good thing that Carmen could probably speak to is that we have electronic prescribing privileges here at Morehouse Healthcare for controlled substances. So we definitely can help in that element if it needs to be done.
Dr. Smith, thank you for mentioning that. I do think that's a great opportunity through our prescribing, e-prescribing through the mobile device, and that certainly gives providers more flexibility in being responsive to patient care and patient needs, as well as that integration into the EHR allows for, and the PDMP allows for flexibility in making sure that medication reconciliation, I can't even speak this evening, medication reconciliation is on point and accurate. So.
Okay, we'll move on to the next question. Our next question comes from Maya, and her question is with regard to retention rates for telemedicine patients versus patients who attend live or in-person visits. Have either you, Dr. Smith, or Dr. Mechanic noticed differences in retention rates between telemedicine patients and those patients who most frequently come in person?
So I'll say that there is data around that. I didn't track that, which I think I should have. But there's a lot of data around retention of patients via telemedicine, and we took some of that data and we actually leveraged it to introduce a couple other programs. Ironically, we didn't track it ourselves. But yes, there's some information that, and it makes sense, touching base with someone on their phone, because if they have their phone and you're on your computer, may be more accessible and may actually increase retention than in-person visits. But I don't have the exact numbers from our program.
We're still relatively new, so we had our first visit in September, so we don't have our full set of numbers for the entire year in terms of retention rate. Well, I will tell you, it's the no-show rate for our clinics now was about 13%, which was much higher than MGA, down to about and we have about 1,700 no-shows for Morehouse Healthcare in general across the board. As far as telemedicine is concerned, again, it's kind of a buy-in type of thing for the providers and the patients. So what we've noticed trend-wise is if the patient actually does the initial visit, typically they continue to engage in the program setting. Sometimes along the way, whether it be technology or just the patient comfort level later on or copay, they may not get into the actual first visit type, but once they do, our retention rate from that perspective has been excellent. And part of it is just because the time saved. I think on average, when the data that we have as far as tracking is, we have saved 1,600 miles round trip, but also we had patients in Dubai, which kind of skews our data, and average about 90 minutes saved in time lost from work, and about 90 miles round trip. So I think that is going to continue to build upon the data that you're asking about.
Thank you. This question is for all three panelists. Recognizing that there has been a recent closure of 120 rural hospitals, how do you envision telemedicine impacting rural health?
So I'll be the first to tackle this. It is incredibly unfortunate the way that rural health hospitals are closing. We've seen that as well up here in New England. What I will say is I was in a meeting just last week, and we were actually trying to tackle this. And one idea that someone had that didn't cross my mind is, I represent Beth Israel Deaconess Medical Center, and what if we had just a clinic that we opened, a couple, 100 miles west of here where there aren't many hospitals, and we just opened the clinic there. You have a nurse there, you have some staff that can draw labs or, maybe do some vital signs. Then you actually have that doctor visit so we can provide oncologic care, for example, or even primary care while that patient may be in western Massachusetts, or rural healthcare system. So again, we don't know. I don't know the answer for healthcare systems that are closing and the misfortune that is, but we're trying to figure out how do we address that. And so that is one opportunity that was just unique, and I hadn't thought about that. And just, what if we set up shop? And we don't have our doctor drive, 200 miles away, because those visits may, an oncology visit only may happen, 8 times a week, and we want to accommodate the patient's schedule. But what if we just set up a wing of our hospital, and we have that oncologist check in maybe on Mondays and have appointments. Maybe on Tuesdays it's something else, or we figure out a system for that. So that's one thing that we thought about.
I think that is very unfortunate, like Dr. Mechanic says, in terms of like the closure of rural hospitals, especially when you're seeing an increase in maternal mortality for women of color. So there's definitely this space there that we need to address, and it's coming, to be honest with you. We have the CVSs that are doing telemedicine and providing that care. The next step is going to be Walmart. It's going to set up some type of kiosk or a one-stop shop to provide at least some ancillary care for patients. So we as providers need to be in those spaces so it's not so commercialized, but more so that it's done the right way so patients have the type of access that they really need, and not just, someone seeing an opportunity to make money. So the other, here at Morehouse, again, I have to always plug because we're leading advancement of health equity. We have what's called a Hill Clinic, which is a free clinic. And they have a mobile van that goes out to some of the rural areas in Georgia. So what we are trying to do in terms of bridging telemedicine is for those, after the patients are able to kind of establish care with the mobile clinic, having follow-up to be done utilizing telemedicine. Because, again, Georgia is very friendly, but there's still some type of rules that you have to abide by. Again, I think it's coming. We just need to make sure as providers that we're at the table and it's not coming down from other people.
And I certainly agree with Dr. Mechanic and Dr. Smith. It is certainly unfortunate to see the rural hospitals across the country closing, and especially here in Georgia because it's so close to us. There are lots of opportunities for us to support them and try to fill that gap as Dr. Smith said, there's some commercial entities that have come together to provide some of the services, but also here at Morehouse School of Medicine, Morehouse Healthcare, we provide some additional services as well, as she mentioned. And as well as, I would say the Morehouse is a big advocate and working with the state around the rural health initiatives.
Thank you. I think our next question is relevant, although it may for some be very obvious. Can you please tell us what is the difference between telemedicine and telehealth?
So I try to touch upon it, and it's not clear to a lot of people, so the confusion is definitely echoed by many. I define telemedicine as the actual practice of medicine via some kind of secure digital modality. Telehealth, a lot of people will describe it as all of the digital health integration into the healthcare system. It's like the difference between actually caring for the patient, providing that medical care. A lot of even genetic counseling you don't have to be a physician or a nurse. It's really any kind of medical care, education versus the healthcare system that is telehealth. At least that's how I define it. Maybe Dr. Smith has something else to add. I don't know.
Telehealth right now because we're providing you with educational service. So I agree.
Can you please share your perspective on the importance of an EHR system being integrated into your telemedicine platform?
Certainly having an EHR system makes things a little bit more synchronized and easy to kind of like navigate, but it's not an absolute. Right now we use Protocol, which is not integrated into our EHR. Partially it's because that was a decision that we made as an organization. We just started off with a new platform. We just wanted to be sure in terms of like just giving that access in terms of the integration component. And so we're still able to actually do the visit type regardless. So what we've done in our clinics is have two monitors up, one monitor where we do our charting, the other monitor where we actually do our visit type. A lot of providers don't necessarily always type and do their visits while they're on a visit. They sometimes chart afterwards. I think the important part is being able to have access to your EMR system to be able to review patients' records, look at any type of outstanding labs that need to be done or reviewed.
I agree. One thing that we've encountered is what if a patient wants all of their medical records from your institution? Just trying to figure out really, how do we take in the health record from the telemedicine visit? So that's something that we've actually contemplated a lot. So in many of our telemedicine programs, we use a different vendor essentially for the telemedicine, but then what we do is we cognizantly take those medical records and upload it into our medical centers information, EHR, because ultimately, if a patient identifies themselves as having gone to that visual defect
from an education standpoint,
they will likely want the records from all of that.
Certainly they are.
So I would just counter it if that's something that we considered and that we're
to make sure that the telemedicine platform is aligned with your
but I don't know
functional
what the right
EHR.
answer is.
For multiple reasons, not just for efficiency, but also, as both doctors have mentioned, integrating that patient care. I'm going to shift gears a little bit and talk about from a CMS perspective. I do think that at some point, particularly around the measures related to the quality payment program and the different EHR incentive programs, that telemedicine will become a measure and a way to meet the criteria related to health information exchange and summary of care documentation.
This is a field that is getting ready to explode. It's been around for over 30 years, but it's just starting to kind of get the traction that it needs. And as you get this younger generation who's all about Facebook, Instagram, and instantly having questions answered, you want to be able to cater to them, in addition to the patients who are on the other side, our baby boomers, who can't come into the clinic, who can't don't recognize what medications that they're on. So you can utilize this type of modality to really improve their care, their well-being, their livelihood.
Thank you very much, Ms. Hughes, Dr. Smith, and Dr. Mechanic. And on behalf of the Morehouse School of Medicine, Morehouse Healthcare Telemedicine Program, and the Georgia Health Information Technology Extension Center, we thank each of our attendees for attending today's webinar, and we hope that you have a wonderful afternoon.